Good morning. The House Human Services Committee now will come to order. And as always, I'd like to remind you that this meeting is being recorded, so please, would you silence or mute your cell phones? What I'd like to do this morning is begin with some introductions of the members here. So let me start going from my left to right. I'm going to ask the members if they would introduce themselves, please.
Ronnie Green, Legislative District 190 out of Philadelphia.
Morning, Chairs. Tara Khan, 194th District, Philadelphia.
I guess I'm next. Okay, Malou McKenzie, the 131st District, part of Northampton County, part of Lehigh County, and part of Montgomery County.
Ann Flood, 138th District in Northampton County.
Arvind Venkat, 30th Legislative District, Allegheny County.
Good morning, everyone. Representative Jose Gerard from Philadelphia.
Good morning. I'm John Schlegel, representing the 101st Legislative District in the heart of Lebanon County.
Good morning. Representative Jessica Benham from the 36th District in Allegheny County.
Good morning. Jim Prokopiak, 140th District, Lower Bucks County.
Good morning. Mark Anderson, 92nd District, Northern York County.
Thank you. I believe we have one person virtually. Would you like to introduce yourself?
It's Joe Hogan, Bucks County.
Appreciate that. Let me begin with some opening remarks. Today, the committee is holding an informational meeting to receive updates on performance-based contracting for residential and supports coordination services for individuals with intellectual disabilities and autism. This meeting continues the committee's examination of the proposal following our prior informational meeting held during the 2023-2024 legislative session. So this is an important conversation we'll have today. I'm going to ask Chairman Heffley if he has any remarks he'd like to make before we begin.
Thank you, Chair Williams, for scheduling this informational meeting. Since we last addressed this issue, the initiative has significantly progressed, and I look forward to hearing about its implementation. As we work to improve the quality of services for our constituents, we also must ensure that the services are accessible, including in all rural areas of the state, and that the providers are given the proper level of support to succeed within the program structure. Thank you to Deputy Secretary Ahrens for joining us here today.
Chairman, thank you. We're pleased to welcome this morning Ms. Kristen Ahrens, Deputy Secretary of Pennsylvania's Office of Developmental Programs. Deputy Secretary Ahrens will provide an overview of the department's progress on performance-based contracting, including outcomes from the first stage affecting residential services and plans for the second stage involving support coordination. Deputy Secretary Ahrens, I want to thank you for being here today. Please turn your microphone on, and whenever you're ready to begin, you may proceed.
Great. Thank you, and good morning, Chairman Williams, Chairman Heffley, members of the committee. I am pleased to be here this morning to provide you this update. I do have a slide deck, so you have prepared testimony that's got a little more detail to it. I thought talking through with a slide deck would actually probably be a little more helpful. I'm also happy to take questions as we go. It may make sense for me to present on residential, stop there, and then move on to supports coordination after that, because this is dense material. All right, well, let me start with, you can go ahead to the next slide. So in terms of performance-based contracting and what the Office of Developmental Programs is trying to do with performance-based contracting is, as Chairman Heffley indicated, this is about quality improvement in our services. And there's sort of four main areas that we have focused on in terms of performance and trying to correct some real challenges that we face in our system, and to improve quality overall for individuals. So those four areas are sustainability, access, workforce, and clinical capacity. And in terms of sustainability, I imagine there isn't a member of the House who hasn't heard about the waiting list that we have at the Office of Developmental Programs and what feels like a pretty intractable issue with the waiting list. We have been talking about the waiting list since ODP had home and community-based services. We have a waiting list for these services. You also, I imagine, there probably isn't a member who hasn't heard about the workforce issues that we face for services for people with intellectual disabilities and autism. Our system has historically been very heavily reliant on residential services. And when I talk about residential services, the part that we're very heavily reliant on is your licensed community living arrangement. Typically, these are 1 to 4 people, and they are very heavily dependent on staff, like in terms of a staffing model. That is a very intensive model in terms of resources. It is also a pretty expensive model of doing services. And so while we have 15,000 people receiving residential services, we have 11,000 people on a waiting list. So when I talk about sustainability, these are the issues that we have to fix. We have to do some rebalancing of that. And so, in terms of sustainability, some of our focuses, our service array in the Office of Developmental Programs is very robust. We have probably about 40 different services that are available to people, aimed at anything that a person with intellectual disabilities or autism may need of all ages. Remember, we serve all ages, to remain living in home and community-based settings. So that is, we have family support services, we have respite services for families, we have all kinds of different therapies, we have a lot of services aimed at employment. We have services that can come into those private homes, and then we have the residential services. And we've been so heavily reliant on those residential services. We really need to grow. We have 3 models of residential services. The one I described is the primary model. We also have something called life sharing, which is kind of what it sounds like. This is where a provider manages the overall person's plan, but they work with a life sharer, usually a family or family member. The person with the disability lives in that home and shares the life with that life sharer. That model is well less expensive, and it's also, in terms of desirable, that is the model, when we look at satisfaction that people have for service models, that is our highest satisfaction, because people are truly belonging. They are truly, engaged in family life and the rhythms of family life. We also have a model called supported living. So these are all 24/7 residential services. Supported living, again, what it sounds like, this is not a licensed home, this is someone's private home, but they have 24/7 on-call staff or staff in the house. Those models, again, much less expensive. Those models, much less reliant on traditional staffing. So when we talk about sustainability, those are the places that we have to move the system. We will always have a need for those licensed community homes, but we have people living in those homes that could be served in those other models, and we need to do a better job as a system of really building up our capacity in that other side. When it comes to workforce, you've heard the wages, you've heard that people can't get services because providers can't hire staff. And this isn't a problem that's going to go away, right? Our demographics don't support this problem going away very well in terms of who's available and the demographic for the workforce. So we have pretty aggressively in performance-based contracting tried to address this. And number one, we have been for a long time really in an effort to professionalize our workforce, the direct support professional, and part of that is credentialing. There are national credentials available, and we have said we want to move to our workforce having these nationally recognized credentials, which also means when a provider hires somebody with a credential, they know what they're getting in terms of training and competencies because it's been evaluated, so it's portable. We want to make sure that, for our direct support professionals who are supporting people with some really complex and challenging needs, that those wages are commensurate with the work that we're doing. So looking at those wages, paying providers for their performance, and making sure that there is the funding there to address the wage issues for DSPs. We have to, as a system, we have had a technology initiative for years. This really bumps up that technology initiative. There are individuals who can be supported in part by better use of technology. They can be more independent, they can be healthier, they can be safer. not a solution for everyone, but in every instance where we can replace at least some staff time or improve someone's life through the use of technology, we should be doing that. So that's in terms of workforce, looking at all of these different solutions. In terms of clinical capacity, our when we look at the population that's coming to us for services, if we look over the last 10-year span, the acuity of support needs for those individuals has increased tremendously, and we have data to show that. So people come to us, again, these are lifelong disabilities. People are aging into more disabilities, right, as our population ages. We have gotten better as a system at identifying people who have co-occurring serious mental illness and autism or intellectual disability, or all three. We have gotten better at identifying people who are inappropriately in our corrections systems or in psychiatric care that really could use the specialized services in our system. So that all presents to us as people with some very, very complex and acute needs. And we have not kept up with the clinical capacity that's necessary in our system to do that. So lots of efforts around crisis intervention, de-escalation, understanding trauma. So this is amping up the clinical capacity and the expectations for our providers in this space. And then the last thing, again, this is, I can't imagine there's a member who hasn't heard, about the access issues. That I have a son or daughter with a disability. I've been waiting for a residential service for 2 years, 6 years, right? And some of that is waiting list. And some of that is, for some of our folks with most complex needs, it takes a long time to get an appropriate home with staffing set up for them. And so we have, historically, our system has paid for the capacity that we needed yesterday, right? We pay retrospectively to providers. And we have never really thought about paying for the capacity that's needed, to have some capacity. So someone who is stuck in an inpatient or an ED or in a county jail can get out of that into an appropriate setting that's supportive for them within less than 90 days, 6 months, right? So we have, part of the effort here is to make sure that we are more responsive to people's needs and that we can more timely address those by having some capacity in our system. All right, next slide. So those are the major areas that we're trying to address here. In terms of timing, the last time I presented, we were in the midst of moving to the performance-based contracting for residential services. That was approved by the federal government last year. That was effective as of January 1st of 25, and again, it included those 3 residential services, which serves that about 15,000 Pennsylvanians receive those services. We have currently, with the federal government, we submitted in July and August amendments to our applications that will give us the authority to move supports coordination into a performance-based contracting arrangement. And for us, supports coordination for anyone enrolled in one of our home and community-based waivers, which is about 41,000 people, they have supports coordinators through those waivers. For all of those individuals on our waiting list, we have Medicaid-funded targeted supports management through the state plan. So we had to amend all of those because most of our supports coordination organizations, all of them, have some combination of people on those different waivers, people in targeted supports management. So all of that will be moving into a performance-based contracting arrangement with those supports coordination organizations. We have had, back and forth with the federal government. From all signs that we can see, it does look like these amendments that we will be effective on January 1. This is something we have been talking with the federal government since 2023 about. So none of our applications or what we're trying to do here are a surprise. So I'm pretty confident we'll be fine for that January 1st effective date. All right, next slide. So in terms of performance-based contracting, this change in our authority with the federal government, the 1915B4, that it runs concurrently with our 1915C and our state plan amendments means that we have the ability to really begin aligning our payment with the outcomes that we seek as a system. Historically, and for the services that are not included in here, those are straight fee for service, and we have statewide rates. We pay the same fee for a unit of service, whether or not it's of high quality and or it's of low quality and just meets the basic regulatory standards. So having this arrangement with the federal government, the authority under B4, allows us to use alternative payment methodology so that we can really begin to use some value-based payment to incentivize providers to support individual outcomes that have been identified and system outcomes through the use of performance measures. So in terms of these performance standards, the providers that will have contracts are the providers that can meet the standards that are published. We brought all providers in for residential. Every provider that was enrolled at the time, they all came in, they all were assigned a tier, and we will be doing the same with supports coordination. But to maintain those contracts, providers will need to continue to meet the standards. And then how we are looking at the value-based payment, I think, over time, our ability to really do this alignment will increase. You'll see by the design that a lot of what we're doing now is very much about capacity building in the system for providers and supports coordination organizations to be successful moving to this new arrangement of performance-based contracting. But ultimately, there's sort of three different ways that are already cooked into the structure here to support value-based payments. So for supports coordination, we will have a new rate methodology. Currently, that is something that we pay in 15-minute units. We will be moving to monthly payments and then pay for performance opportunities, which we also have for residential. For residential, providers who have met the performance standards, the higher performance standards we have divided into sort of 4 tiers. The providers meeting the higher performance standards receive rate add-ons. So they have essentially enhanced payments because they have met a higher quality measure standard. All right, next slide. So for residential, as I said, there are four different tiers. Primary, and you'll see primary is where most providers fell out, and we thought that would probably be the case when we rolled this out. And that was providers that meet the standards that were at the time and some additional standards. Those standards were very much aimed at beginning to build the capacity for providers to meet those 4 main areas. So start working on, we need to see plans related to workforce and addressing credentialing of workforce. We need to see how you are arranging yourself to support employment for the people that are in your service. So that's primary. Select is mostly characterized by the kind of key additional standard there is to be a select provider. It's a provider that has to offer not only that residential habilitation, that typical licensed community home, but also either supported living or life sharing. So those providers have to offer 2 of the 3 different residential services so that individuals really have a choice of that continuum of services. And we've built in expectations and pay for performance for providers who successfully move people from those licensed residential to a supported living or to a life sharing setting. Select providers also had a number of different standards related to clinical capacity, training for staff, so expectations around training for autism. They had additional standards related to credentialing. They actually had benchmarks in terms of where they had to hit for how many staff were being credentialed. And then conditional is providers who are under either a revoked or provisional license. So they are in conditional until they return to regular license. All right, next one. And then all providers had an opportunity to come in. We had two-tier determination. So one of the things when we first published this, there was providers were pretty clear that this lift and the pace of it were of real concern to them. And so through the public comment period, we ended up having giving providers an option of when they could submit their data and when they could begin their contract. And so we had two different tier determination periods. At the end of it, for this this calendar year, we ultimately had 410 providers that met the primary status, 16 that met that select status, and 7 that met clinically enhanced. And although the number of providers in those 2 advanced tiers is only 23, it does represent 17% of the entire population in supported living, in one of those advanced tiers. So that 17%, those providers do serve geographic areas across the Commonwealth and obviously a pretty sizable portion of the population. One of the other things I'd draw your attention to is with performance-based contracting, one of the other things that we wanted to make sure that we were doing, a complaint that individuals and families have had for a really long time about our system is there is no way to make an informed choice about providers. There's no information available. If you're really, skilled, you can dig in and find old licensing reports or whatever. But that individuals and families, would ask us, we need a Yelp, right? We need some way to identify and make choices about providers. And so with performance-based contracting, there is now an available online directory which lists which performance tier those providers are in. So there's little information about what the performance tier means. If anybody wants the full length of that, that's all publicly available as well. But that directory at least gives individuals and families a sense of where their provider falls in terms of that that performance evaluation. So that is up and publicly available. We will be doing the same thing for supports coordination. All right, next slide. And we're really pleased that after, we're not even a year into residential performance-based contracting, and we are already starting to see some really nice improvement in some key areas for us. So the first one is, I talked quite a bit about how important it is that we're really looking at that full continuum of services, whether that is life sharing, supported living. For supports coordination, we've got a lot of pressure for supports coordinators to make sure that before they're looking at these residential solutions, they're also looking at that whole package of non-residential services that could and does support many people. On the residential side, we are really pleased. We've had a 15% increase in providers who have enrolled to be serving people in life sharing or supported living. So again, expanding the access for individuals and families to those other models. And in terms of impact for less demand on workforce, that this canon will be significant. And in terms of cost savings, again, these are very big cost savings for any individual that's shifting from a residential habilitation to life sharing or supported living. So we're really pleased to see that. We have a lot of emphasis on competitive integrated employment. If we look at data, look at individuals over a 10-year span and their total cost over that time, people who have employment ultimately their services cost less over that long span. We have seen a 1% increase in employment. Now that is limited to the lower acuity groups, but we are pleased to see just in this time period a 1% increase in employment. Another area really pleased, one of the things that's critical to know about the population that we support at ODP is we have really significant health disparities. On average, people with intellectual and developmental disabilities have a 15-year shorter lifespan than individuals without. We have higher rates of diabetes. We have higher rates of hypertension. And so there's a lot of emphasis in our performance measures on wellness and health and expectations that providers are aggressively addressing this. Same thing in the supports coordination performance measures. And one of the key areas, individuals that we support are at very high risk for a number of different things. Choking is one of them. We have a fatal 5, right, that we put a lot of emphasis on training our DSPs around. Choking, constipation, dehydration. We have had an 80% reduction. We have a screening that is normed for our population that we require our residential providers to do. We've had an 80% reduction in individuals who have no screening and a 79% reduction in missed screenings. So in terms of catching things on the front end, aggressively working on preventative care, wellness, we're, again, not even a year in, we're starting to see some really nice improvement. And kudos to our provider community, because again, this is a very big lift for our providers. And we have a lot of performance measures that we are expecting them to be focused on all at once. Another area we're pleased to see, we have a 5% reduction in what we call our incident reporting fidelity. And very specifically here, we have a reduction in unreported instances of abuse or neglect. And I assure the committee we do very well in this to begin with. We have less than 1% of unreported abuse and neglect incidents to begin with, but we would like to have 0. And we have seen even a reduction in that. So we're really pleased. And then the last thing, just another great example of work that our providers are doing. We use a measure that is a HEDIS measure from physical and behavioral health. That is, after a psychiatric inpatient hospitalization, our health plans are, we look at how an outpatient visit within 7 days and 30 days. And for us, this is also important. More than 40% of people with intellectual disabilities and autism also experience a serious mental illness. So we said we set percentages and said we want to make sure as a residential provider you've got 24/7 responsibilities to support this person, that they're getting that follow-up outpatient care. We have had a 20% increase in that outpatient care within the 7-day and the 30-day, just in this not even year of performance-based contracting. So again, really, really pleased to see some of these improvements, and I expect that when we pull the 2025 data, we'll have even better story to tell on these things. All right, that's what I have for residential. So do we want to stop there and do some questions or comments on residential, or do you want me to? I can go through the end. Either way.
Let me just pause and see if there are questions right now from the members of the committee. Representative Flood.
Good morning.
Good morning.
Thank you for your testimony so far. I think you've been demonstrating that you have been making some improvements. And so one of the questions that I have when we're talking about life sharing and supported living, that I think you had stated that that's the individual would be living with the family, right?
For life sharing, it's still all 3 of those are overseen by a provider. For life sharing, the provider essentially matches. Typically, it's a family that takes a person in and provides their care in that family home. They become part of the family. They receive a stipend. The provider agency is still responsible to make sure that the person's plan of care is carried out.
It's their own family, though, typically.
We do allow that.
Yeah.
As of 2017, we do allow relatives to be the life sharers as well. Yes.
And so if it's their own family, I'm trying, because I get a lot of questions back in my district from families who have children with disabilities. And one of the issue that keeps coming up, and I'm wondering, and this applies into this life sharing, is that 40-60 rule.
So
is that completely different?
It's
from
completely different. Yeah,
okay.
the 40-60 rule applies to the non-residential services. So so the life sharing by a relative is actually something that we have said to families. If you are providing and are looking to do more care, and you don't have other people coming in to provide that care, you could look at doing life sharing through a relative. So yes, that is an option for people who need more than that 40 we don't pay for overtime in those models anyway.
Yeah.
The 60-hour limitation.
Okay, because I'm trying to get myself informed so I know how to better direct our constituents in dealing with the frustrations that they have, and everybody's looking for answers, and I know everybody has an issue with that 40-60 rule. So if there's other avenues to send them down to explore, then this is great. So.
And life sharing would be one of those options. And we've actually seen we've had an initiative around children with medically complex conditions and making sure that they are not living in facility-based congregate care. No child should be living in a congregate setting like that. And so we have prioritized their enrollment in the waiver, and we have had some incredible situations where relatives have done the life sharing. A nurse who was a full-time nurse before, who takes in a niece with the oversight and other support of a residential agency, moving that child out of a congregate setting. So yeah, we've seen some really, really lovely life sharing situations like that.
And do you find when you have people that are doing these situations, you're still having a hard time finding the providers to come into the homes and do what they need to do?
For both residential and non-residential,
Yeah.
yes. I mean, we still have access issues, and some of that is depending where in the state you are. We have areas that I think, and which services, there are areas where that is more of a challenge. And most of it does go back to that workforce issue. So there may be a provider there, but they have to hire the staff. They don't have the staff to do it.
Okay, thank you.
Yep.
Representative Schlegel has a question, and then we'll keep moving.
Okay.
Thank you, Mr. Chairman, and thank you to the Deputy Secretary for being with us. I think this is an appropriate juncture to ask this question. Actually, I want to make a statement, and I just want to make sure that when I go home and talk with constituents, that I'm sharing this idea of performance-based contracting accurately. So if I talk with constituents and I say that performance-based contracting is used by the Department of Developmental Programs to determine if care providers are doing an effective job, in very broad general terms, is that an accurate statement?
I would take it further than that. So I would say, remember, this is limited. We have about 40 services, and we're applying a performance-based contracting arrangement to 4 of them. What I would say is performance-based contracting is an effort to hold providers accountable for quality measures.
Excellent. Thank you very much. And I always get the chance to interact with advocacy groups as well as individuals themselves with disabilities, so that's very helpful. Again, I appreciate your testimony. Thank you.
Thank you. Representative Bellman has a question, and then Deputy Secretary will continue with the remaining portion of your presentation. Representative Bellman, please.
Thank you, Chairman, and thank you, Deputy Secretary, for being here. I just wanted to see if you had any stakeholder feedback about the performance-based contracting.
Volumes, yes. We started this conversation with stakeholders. We have an advisory committee that's made up of, we have 41 stakeholder groups that are represented on that advisory committee. We started this discussion back in 2023. We published a concept paper before we did anything, got a significant amount of feedback on that concept paper from really across our stakeholder group, made significant changes to what we ultimately then put out for another formal public comment period with residential services. The residential measures themselves were developed by a stakeholder group that included people with disabilities, families, providers, counties, supports coordination organizations, and then we did the same thing for supports coordination. So multiple opportunities at public comment, and then stakeholder groups that actually developed the specific measures. So there has been an incredible amount of public feedback, and it has made the product a lot better. One of the things that changed on residential that we're really pleased with from public comment was we added a pay for performance to support building of capacity in rural areas. So that was not part of the original, and that definitely makes the whole thing much stronger. So no, if you look at what we published from concept to what has ultimately been approved on residential, what we ultimately sent to the federal government for supports coordination, there are very significant changes. All of them make it a much stronger systems change.
Awesome. Thank you.
I'll continue.
Excellent.
Sounds good. All right, let's go to the next one. We'll move over to supports coordination. So again, these are our amendments to our federal agreements are with the federal government right now for approval for January 1 effective date. All of our supports coordination organizations currently have an opportunity to contract with us for performance-based contracting. I am pleased we have received new signed agreements from all of them, indicating that I think they all intend to submit their data and have a performance evaluation to continue doing services. We have some of the design for supports coordination is quite different. It's quite different. Again, back to the public comment, we made very significant changes in supports coordination. We initially conceptualized having sort of these tier determinations as well, and having different tiers for supports coordination. Through the public comment period, got great feedback that supports coordination, unlike residential, it's a standardized service that should be uniform, and we shouldn't think about tiers. And so what we did instead was we are phasing in all of the measures. So all over time, you can see, and we published them. So, for this next contract year, here will be the expectation. They already know what the expectation is for the following year. And all of those are building. Basically, the first year is we're going to build capacity for supports coordination organizations to meet the measures. Next year, we're expecting, so you've now, as a supports coordination organization, gathered your baseline data on all of these different things. We are expecting in the second contract year that you have increased your performance, that you've improved your performance in those areas. Eventually, and some of these are the third year, some of these are further out, we will have statewide benchmarks for a number of the different performance measures. So, we're phasing in all of these measures for all supports coordination organizations. One of the things that this new operating under B4 really allows us to do is offer new flexibilities for our supports coordination. Supports coordination is an incredibly difficult job. Our service system is very complicated. ODP has 4 waivers. We have different financial caps. We have different limits. We have the 40-60 rule. We have all of these different benefits, different provider qualifications, and supports coordinators are also interfacing with children and youth, and with behavioral health, and with physical health, with Medicaid, with Medicare. They are interfacing for people who have forensic involvement, with the criminal justice system. And we're expecting them to know housing and to know employment. All of these are totally specialized fields. And so what we have said, we have experienced some very high turnover. You typically probably hear about direct support professionals, but at one point, our supports coordination vacancy rate was as high as it was for direct support professionals. The turnover rate, very high. And no one can have that level of expertise if they are turning people over in 12 months, right? So what we have said is we, in addition to paying them differently, we want to give them some different flexibility to say, to me, it doesn't matter if it is the supports coordinator himself that knows all of this, that is making all of the contact, that is doing all of the different functions. It is the responsiveness of the supports coordination organization. So we are starting this with, we're allowing them to use what are called associate supports coordinators to do certain functions. And we are measuring them on responsiveness. We want individuals and families to be able to have the information in their hands as quickly as possible, and it doesn't have to come directly from that one person anymore. So we're really trying to free up the organization's ability to have the expertise in-house and meet that need how they're going to. If they decide to have a facilitator who's doing person-centered planning or we have these things called life course tools. If they're using that with a peer-to-peer model, we have peers trained across the state to do that, another family member, wonderful. As long as we are seeing the outcomes for the individuals, we are going to move away from having so much activity that relies on one person and one person's expertise. I think we believe that'll help us get to these system outcomes. All right, next one. So the pay for performance areas, these go, mostly these are for both residential and supports coordination, the primary areas. So for both residential and supports coordination organizations, we have pay for performance opportunities for transitioning those individuals from that residential habilitation to life sharing or supported living. We have pay for performance opportunities for adopting technology, and that is everything from we are beginning the expectation that residential providers have electronic health records, to making sure that technology is in the hands of the individuals that they support. Competitive integrated employment is a pay for performance area for both. Credentialing is a pay for performance area for both supports coordination and residential. The rural provider capacity, as I shared, is for residential, and we will be rolling out those payments. So later this fall, we'll roll out the availability of those for 26, 27. And then community inclusion is one we have not rolled out yet, but we will have community inclusion pay for performance opportunities as well. All right, next slide. And then lastly, and hopefully I've emphasized this enough, we have at the Office of Developmental Programs been very committed to the continuity of care. These are big systems changes. This is very heavy lift for all stakeholders, obviously, particularly the residential providers, obviously the supports coordination, but really for all system partners. And we have taken many steps to make sure that there is a continuity of care for individuals. So that is, we brought in our providers, even those that were operating on revoked license, pending appeal. We didn't necessarily have to contract with them. We did. We brought all of those providers in and have really extensive efforts, both in terms of those pay for performance to support capacity building for them to be able to meet these measures, and then extensive efforts in terms of provider support to make sure that our providers are getting what they need to be successful to meet these new standards. But this was very much aimed at, we were trying to avoid at all costs disruption of care for individuals that are receiving our services, and make sure that we are improving the quality of all of our providers and really bringing them with, so that we have a good solid network of providers across the Commonwealth. So we have put into place, and I don't need to cover all the detail, but everything from dedicated website, lots of webinars. We have virtual office hours that have been very popular with our supports coordination and our residential providers. We have dedicated resource accounts, and generally our providers have expressed a lot of appreciation for the level of responsiveness that the department has had in supporting them to meet the new measures. So that will continue with supports coordination. We want them all to come in. We want them all to be successful with us. And then the last piece is just, another key to this is continual stakeholder engagement. Again, these are really big changes to the system, and it does require just continual communication so that all of the system partners can effectively carry this out. And I'll stop there. Happy to take more questions.
Deputy Secretary, thank you so much. I want to pause and just take questions from the committee at this point. Representative Anderson, please.
I don't really have a question. I would just like to say this is one of the most comprehensive, competent, and helpful testimonies I've heard in my short time in the House. This is a heart issue for me, like you, with personal experience. And you've just expressed not only your mind and a lot of information. I don't think I've watched you look at one single note the entire time, which is quite impressive. But it is very evident that this is both intellectually important to you and heartfelt intellectually to you. So not only do we have a lot of information, but you have really inspired with your testimony. So I just want to tell you I appreciate it very much.
Thank you so much.
Thank you, Representative. Ann Flood has a question. Representative.
Thank you again. And as Representative Anderson said, it's been extremely comprehensive. The information that you're providing is a lot of great information. But one of the questions I had kind of goes back to the beginning when you were laying out these 4 residential provider tiers. What's the percentage of individuals being served by the 23 providers in the provisional tier? Can you elaborate on the process to either remove their opportunity for supporting individuals or return them to the primary tier?
So when they, I don't know the percentage offhand. I'm happy to get that for you and provide that. It's not 17%, I can tell you that, but we can calculate that and provide that. And I actually want to say, since that slide was created, I think that number has actually decreased. So for the providers that are on conditional, they also had to submit applications, and we evaluated their tier. When they come off of a revoked license that was under appeal, or they come off of a provisional license, they will be placed in the tier that they met the criteria for. Now, over time, so there's a couple of things, because this is residential, you now have, and again, when I talk about the lift for providers, they are still operating under all of our program regulations, all of our licensing regulations, and now a complex matrix of performance standards. So when I say this is a lot for residential providers, it is. I think eventually over time, the question of whether or not, how we handle a revoked or provisional license and decisions to continue contracting can and will change. We have a lot of capacity building to do in our system before I think we can make those decisions. But the other thing that we have committed to providers is, and we'll have a full year's worth of data soon here, is that we believe that performance-based contracting will give us the opportunity to reduce the regulatory burden that providers operate under. So if a provider can meet all of these performance standards, if they are hitting, they're the select or clinically enhanced provider, our theory is that they probably do very, very well in terms of licensing. And so we can think about reducing the regulatory burden that they're actually under in terms of oversight. But we are going to bear that out in data first, so we'll review the first year. But I'm happy to provide you the percentage on conditional. It was frankly one of the things coming into this in 2023 that we cited was we had hundreds of people literally across the Commonwealth that were being served on any given day by a provider who was on a provisional or revoked license, and we intend to change that.
All right. I know that Chairman Heffley has a question. I want to insert one here as well, though. Are individuals in the higher needs group 4 and 5 primarily being served by providers in the select and clinically enhanced tiers?
So I wish I could answer that simply. So one of the criteria for a clinically enhanced provider is that they have to be serving the top quartile of the population in terms of acuity. So our clinically enhanced providers, by their nature, are serving people with the higher level needs groups. Between select and primary, they are both serving people with very high acuity needs. One of the things that we would like to get to eventually is for our highest, the individuals that present the most complex challenges for us in terms of supporting them, that they are ultimately only being referred to our select and clinically enhanced. We are not there. We actually started the proposal from concept paper we had suggested we would start that upon effective date. We just pushed that date back to 2028. So, I think we're confident that by then we will have the network and the capacity in the system, but we have a lot of capacity building to do between that concept paper and now.
All right. Chairman Heffley.
The credentialing process through the National Alliance for Direct Support Providers. Can you explain how that credentialing will work?
And actually, that's another improvement area that I didn't have up there, and I'm really pleased. We actually we're about to hit our 6,000th credentialed direct support professional in PA. How this works is there are 3 levels of a competency-based credential for a direct support professional. The National Alliance for Direct Support Professionals allows states and providers to submit curriculum that they then review and approve related to their competency standards. DSPs have a certain set of those that they have to meet to hit their Credential 1, Credential 2, Credential 3. ODP submitted, I want to say, there was over 100 different courses. And so we hit on some of the things that are required by regulation, some of the basics. So abuse, neglect, incident reporting, communication, medication administration. So we submitted all of those. So it actually serves, in Pennsylvania at least, it serves to meet some of the basic requirements that we have, plus the other competencies. We have, and I'm thrilled with the 6,000 number. That's a huge jump. We had 1,000 people in July of last year. And what we are hearing from providers that have done a nice job of implementing this is they're seeing reductions in overtime, they're retaining people longer, and the support that the DSPs are providing is of higher quality. So we had some good data going into it before we adopted, this as a path forward, and we are certainly hearing providers saying that that's bearing out. I talked to 2 providers yesterday that had 94 and 93% filled positions, so 6 and 7% vacancy rates.
Deputy Secretary, I appreciate that. We have to release this room, so we have time for one more question. Representative Benham, I'm going to ask you if you'll truncate your question, please, and the floor is yours.
I'll be quick. Thank you, Deputy Secretary. Workforce issues in this space are certainly a special legislative interest of mine, and I'm wondering, I know some of the goals of this were around addressing workforce challenges. Are you seeing any early signs of success there?
So the ones I just shared, we have sort of anecdotally, providers have shared what they're seeing with their own retention and overtime. One of the key performance indicators that we have, and we have the ability to look at these through data, is we want to see the overall vacancy and rate decrease and the retention rate increase for direct support professionals. And I think watching that trajectory will tell us that these efforts are working. We'll start getting data on the adoption of technology, all of those things. We are asking providers to give us data on how many staffing hours it saves through technology. So those are data that we should have in the future.
Wonderful. Thank you.
Yep.
Deputy Secretary, thank you so much. Would we be able to submit questions in writing at the end of this
of course.
Session?
Yep.
Thank you so much. I want to thank you for your presentation today and for providing this committee with really important updates. This is an area of great importance to individuals with intellectual disabilities and autism, the families and the providers who support them. So the committee will continue to monitor progress closely as implementation moves forward. Again, thank you to committee members. Thank you, Deputy Secretary. And seeing no further business, this meeting is adjourned. Thank you so much.